As the humans and the mankind, they would progress, and during the course of progress, the countries will progress, the continents will progress. During the course of progress, we have to measure that where your progress is going. You have to track the progress, and to track the progress, the topics that we are going to talk about is the indicators. So indicators would help you understand that whether you are on the track, yes or no. There are many indicators we need to discuss. We are going to discuss these 6-7 indicators today. So the first thing for us is the mortality indicators. Mortality means the death indicators. Morbidity indicators. But what is morbidity? Morbidity means sickness or it means illness. Third would be utilization indicators, like health services are there, how many are being utilized, or what is the practices of the population over there. Fourth is the service indicators, that what are the services we as government of India or any government of that country, as what are the healthcare facilities which are being provided. Fifth would be socioeconomic indicators, disability indicators. In fact, the socioeconomic indicators, this is one of the most important development indicators. Followed by that, you have the disability indicators. And then in the next video module, we will talk separately about the development indicators, the country development indicators. So in this video section, we are going to talk about the 6 most important indicators which are used for all these topics. Alongside, we will also talk about the ICD classification. So let's get on and talk about the first point. What do you mean by indicator and index? So it's a very basic thing, that indicator. What is indicator? Indicator is just a point in the space. You already know that. What do we mean by objective, target and goal, beta? Do you remember what is objective? Objectives are short term. They are short term endpoints. And then you have the targets, which are mid-term milestones. I hope you remember this, that there is objective, there is targets, and there are goals. So what do you mean by objective? Your objective right now is to study community medicine. That is what your objective. So it's a short-term endpoint. After that, it's not that I'm going to revise. That will be something bigger. So your short-term objective, short-term endpoint is to study community medicine. Then, so please note that the MCQ will be, what is objective, beta? Just write it down. Objective is a short-term endpoint. It is a short-term endpoint. Next comes, what do you say your target? See, I'm not saying what is your goal. What is your goal? Goals are something which are very big, right? So goals are usually unachievable. Goals are something what you desire. My desire is I want to be happy. But what is happy? If I just put a pinprick, happiness gone. So goals are something which are just fancy things. They are usually long-term, desirable endpoints. So I want to be successful. I want to have a lot of money. These all are goals, because every day or at any point in time, you will have a lot of money. But then there will be people who are better than you, right? So you can't say that I want to be the richest person. When you are the richest, there will be somebody more richer than you. So goals are something which are desirable long-term objectives. Like, what is the goal for WHO? The goal is health for all. Health for all is like, you can't achieve health for everybody, because if health is there, then what are we going to do as doctors? Doctors have to be there. So goals are something like which are desirable endpoints. And what do you mean by target? That is what the MCQ comes to you. What do you mean by target? Targets are something which are mid-term milestones. Very important MCQ. Targets are mid-term milestones. Targets are mid-term milestones. So they are usually in the center and they help you understand the track. So you have some indicators. Indicators will be either objective or target. Indicator cannot be the goal. So goals are usually the final impact indicator, that did you achieve it, yes or no, or something like that. So what do you mean by index? Index are composite. They are composite. Composite means they are composite indicators. So index is not a single indicator. Index is a multiple indicators together forms index. So it is a composite amalgamation of indicators. So many indicators together index. One indicator will tell you objective, target or goals. Are we getting it? So point 1. Point number 2, your indicators they all should be valid, reliable, sensitive, specific, feasible and relevant to the population. They shouldn't be like something fancy indicators we keep very basic indicators. So now if you have understood this, let us get on and talk about the first indicator, that is the mortality indicators. The mortality indicators, if we talk, that is we are talking about the death indicators. So the death indicators, we have had a word in the chapter on epidemiology, where we talked about proportional mortality rate, case fatality rates, and all these things. So please note that there is the death indicators. Example for this could be the crude death rate, the neonatal mortality rate, infant mortality rate, the maternal mortality ratio. These all indicators. For more details, you need to talk in the chapter of MCH indicators. Proportional mortality rates, case fatality rates, cause-specific death rates, we talked in the chapter on epidemiology. Life expectancy. Wait, do you think that life expectancy is a death indicator? Answer is yes, because life expectancy, it is a positive death indicator. What do you mean by positive? Because number of deaths in the country or number of chances of dying is inversely to the chances of expectancy. So if the life expectancy is high, the death rate technically has to be low. Are you getting it? It's very simple to understand. It is, please note, for your MCQ exams, life expectancy is taken as a mortality indicator. It is a positive mortality indicator. Please note that as per the UNDP, United Nations Development Program indicator, as per the UNDP, that is the United Nations Development Program for India, in year 2021, the life expectancy was recorded to be 69.7 years. And the maximum life expectancy has been recorded for Hong Kong, that is 84.9 years. So 84.9 as per the United Nations Development Program, it is 84.9 is the maximum life expectancy. India is hovering around somewhere in the middle. The lowest countries would have something around 52, 53 life expectancy. So if you just look at the maternal mortality ratios across the world, of course, the data that you're seeing is older data, the current maternal mortality ratio for India. I hope you understand what is the maternal mortality ratio and maternal mortality rate. I've almost discussed this in the MCH chapter. We discussed about this in epidemiology chapter. We discussed this almost in every chapter that I take, that MMR, maternal mortality rate, is numerator out of the denominator. Maternal mortality ratio is the maternal deaths divided by live births. So the current maternal mortality ratio is 103 per lakh live births. So if you talk about the maternal mortality ratio, this is old data. You can see that different countries will have different MMRs. The second one is the morbidity indicators. Beta, what do you mean by morbidity? Morbidity means sickness. Different morbidity indicators can be there, like we can talk about the incidence rates or the prevalence rates. The details about this can be found in the basic chapter of epidemiology, the basics of epidemiology. What do you mean by incidence? It is the total number of new cases per unit time. It is per unit time. And what is the prevalence? Prevalence is the total cases, which include the old plus new cases. It is always expressed in proportions. It is mostly expressed in proportions or in percentages, right? So for details, you need to refer to the chapter in epidemiology. The next morbidity indicators can be the notification rates, that how many people get the disease. Hospital admission rates, this is a very important morbidity indicators. It tells you about the burden of diseases, different diseases in the society. Also, the average length of stay will tell you about the chronicity of the disease in the society, that is average length of stay. So we will talk a little bit more in detail about the average length of stay, but for now, these are the morbidity indicators. If I just show you the latest data from NFHS 5, that is the National Family Health Survey number 5, which was conducted very recently in 2019-20. The data was released in 2021. Can you see over here that the latest NFHS 5 data, I made a bar charts out of these. If I talk about the stunting and the wasting rates, can you believe that the stunting and the wasting rates in our country is hovering around 20 to 30% of children under 5. This is in under 5. Is around 20 to 30%, and the average underweight child in India is 32%. You can see that the prevalence of anemia in the children less than 5 years is whooping 67%, whereas the diabetes mellitus is hovering in males and females around 13 to 15%. And if we talk about hypertension average is 22%. So these are actually all the morbidity indicators, the latest updated data, right? So next in line is what do we mean by the utilization rates? Utilization means how much services that we are providing are being actually utilized. So are you able to use the lectures? Are you able to use the Q bank? That is what is utilization rates. So we check utilization rates by the immunization rates, by the number of females who get ANC, PNC, antenatal care, postnatal care, the family planning use, Bed occupancy rates and bed turnover rates. So what are these utilization rates? If you look at the MCH indicators, that is again, I've made bar charts out of this NFHS 5 data. If you look on the screen over here, National Family Health Survey, the mother and child health indicators, you can see that the number of females who got ANC during their first trimester, it is good amount of 70%. But can you see that 4 ANCs total, all that is the minimum ANC requirement, was done only by 58% of the total pregnancies that we have. The neonatal tetanus vaccine coverage was very nice, about 92%. The IFA tablets taken more than 100 days. For how many days should a female take iron folic acid tablet? Please note IFA tablets under the Anemia Mukt Bharat, it should be started from second trimester onwards. The female should be taking for 180 days during pregnancy and 180 days she should be taking after pregnancy during lactation. So, but the number of females, can you believe that the number of females who are actually taking IFA tablets is very low, 44%. Then you have the institutional births, which is good amount, that is 88.6%, but still we have around 3% of the home deliveries. So these are actually all that I have discussed is the utilization rate. Next is, let us have a quick discussion about how do you understand about the bed occupancy rates or bed turnover rates. Beta, this is a 2 by 5 star MCQ topic. It can be asked in your exams. Very recently, we got a question on about the bed turnover rates. Let us have a understanding about that. What do you mean by the bed occupancy rate? Bed occupancy rate is like how many bed days was the bed occupied. So for how many bed days? We don't say days, it is bed days of occupancy. That is what is of occupancy is, that is what is bed occupancy rates. Your phone is there, right? So if you have a phone, for how much time your phone was occupied, that is a bed occupancy rate or phone occupancy rate. The formula for bed occupancy rate is what you can see on the screen. It is the total number of bed days used. So we don't say the number of beds used or the bed days used, it is the bed days used. For example, 20 patients, they all staying for 2 days, so 40 bed days used. Common sense, right? So it is the total number of bed days used divided by the total beds available in a year. So total number of beds which are there in your hospital, let us say you have a 40 bedded hospital. So 40 into 365 will be the total bed days we have, and how many bed days it was used, that is the bed occupancy rate. MCQ. It is a very important, it is an essential, it is an important indicator for what? MCQ. It is an important indicator for utilization of the hospital or the healthcare facility. It is an important indicator for utilization of a healthcare facility in the population. Okay. So can you understand that? It is very simple. It is the utilization indicator, that is the bed occupancy rate. Now, how is it different from a bed turnover rate? If your phone is there, you are talking on phone for 2 hours. So there could be a possibility that your phone occupancy rate was 2 hours in a day. Okay. But in that 2 hours, you talk to 10 people or 20 people or 5 people or only one girlfriend, boyfriend. So that could be different turnover rates. Are you getting it? So let us say my bed was there. It was occupied for 5 days in a week. 5 days in a week. So my bed was occupied. In that 5 days, that was an ICU bed. In that 5 days, there could be some patients who came and they were happily discharged. Unfortunately, we lost 2-3 patients, and unfortunately, we had to refer out 1-2 patients. So there could be like people on the bed. The bed is occupied, but that people come and go, or people come and unfortunately die, or they are being referred. So different things can happen. That is called as the bed turnover rate. It is something different from the bed occupancy rate. That is what your question was in your central exam, AIMS exam. They had asked about this, like what do you mean by the bed turnover rate? The formula for bed turnover rate is the total discharge or the deaths or the transfer outs divided by same answer, total beds available in a year, multiplied by 100. What is the MCQ, like what is the use of a bed turnover rate? Please note that it is utilization indicator, but it is more important indicator about the efficiency of a hospital. It talks about the efficiency of a healthcare facility. So usually the bed turnover rates will also tell you whether the hospital is catering to acute conditions or the chronic condition. The bed turnover rate for chronic condition will be high or low. It will be low. For acute conditions, the bed turnover rate will be very high. So for emergency hospitals, trauma hospitals, for the ICU beds, usually the bed turnover rate is pretty high. So that's how it is. So it also differentiates between the acute or chronic care. Chronic care. This could be your next MCQ. So already they had asked that what is bed turnover rate beta? It is a utilization indicator, but it is important from the efficiency point of view. Beyond this, the next similar looking indicators can also be asked in your exam. What do you mean by the bed supply rate? And what is average length of stay? If you talk about the bed supply rate beta, it is the total beds which are currently available divided by the population served. So what does it tell you? Let us say that you are the health administrator, or you are the health minister in the area, and your sign is going to approve that how many bedded hospital we are going to launch. So if we are going to launch a new health facility, that should be 20 bedded or 50 bedded, or do we need 80 bedded? That has to be dependent on something. So that is what is bed supply rate. It is the total beds which are available divided by the population served. It is a public health indicator. Public health indicator. Usually it is said that bed supply rate as per the WHO norms, it should be more than 5 beds per 1,000 population. So that you can say is a bed population ratio is what is a bed supply rate. What do you mean by average length of stay? Average length of stay will tell you about the morbidity. It is actually not a utilization indicator. It is a morbidity indicator. Average length of stay will tell you that what level of sickness and what type of sickness is prevalent in the area. So it is the total duration of the stay divided by the total number of discharges. That is the average length of stay. So please note, this can be your MCQ. What do you mean by the bed turnover rate or the bed occupancy rate? They both are the utilization indicators. Next is point number 4 is what are the service indicators? Service indicators, we just now talked that one of the service indicator could be the bed population ratio. That is actually, these are service indicators. These are the public health indicators. So one of the indicator we already talked, that is the bed supply rate, that is the bed population ratio. We can also talk about the doctor population ratio, doctor nurse ratio, health center to the population ratio, and so on. So if I just show you an old data, I'm not saying this is the latest data, this is just the old data. It's a representative data that in year 2005, can you see that how many doctors were there per unit population? You can see that majority in Punjab area, it was having the highest doctor density, whereas that is the doctor density per unit population. Whereas in areas like Maharashtra, Karnataka, Andhra Pradesh, Telangana, it was a little less, and so on. So different doctor population ratios was there. Also, if you talk about the type of doctors which were available in year 2005, you can see that in rural areas, more amount of allopathic physicians were there in the non-government sector. Whereas in the urban areas, you can see that allopathic physician was kind of less in the non-government. The government allopathic physician would be more in the urban areas, and so on. You can see that nurses are more predominantly, you can see in half government and half non-government and things like these. So these are all the service indicators. You would also like to ponder upon that how much medical colleges we have in India. So medical colleges to population ratio, you can see that the highest amount of medical college to the population ratio has been prevalent in the southern part of India, along with Himachal Pradesh and some parts in the northeastern states from Mizoram. You can see that the number of medical colleges is slightly more per unit population. Next level of indicators would be the socio-economic indicators, that is the number 5. Socio-economic indicators, these are also referred to as the demographic indicators. So they talk to you about the development of the area. So you can have different socio-economic indicators like how many people are rural, how many people are urban, how many people are poor, how many are rich, what is the housing rates, calorie per capita, family size, growth rate, dependency rate, literacy rate. All these are socio-economic indicators. If I just show you the latest data, this is the latest data from the NFHS 5 data, which was 2019-20. So you can see that the number of population who already have electricity in their homes is good number 96.8. But can you see that sanitation, the good toilet facility was available to only 2/3 or 70% of the Indian population, and the internet use in males was very low, like 57% of the males were actually using internet or smartphones. And then if we talk about the literacy rate, as per the NFHS 5 data, the literacy rate in females was 71, whereas in males it was 84. So that is just an example for the household profile of the NFHS 5 data, which actually comes under this socioeconomic type of indicators. Also, you would like to see about the UNDP projection data from for the year 2030. It has been projected that the country is going to have around 150 plus crore population, and the old age dependency would be 9.5, young age is 39.7, sex ratio at birth is 1.1. Please note, I'm not saying the sex ratio as per the number of females per 1,000 males. This is the sex ratio at birth, that is number of males to females, that is direct 1.1. Life expectancy, I already told you that this is the current life expectancy we have in India, that is 69.7 years. So these are some of the socio-demographic, socio-economic indicators. What do you mean by the dependency ratio? We already had a word on this in demography module, but I would like to reiterate over here that the dependency ratio is age less than 14 years and age more than 65 years divided by 15 to 64 year age group. That is the total independent divided by the total dependent multiplied by 100. It is a dependency ratio usually expressed in percentages. It is a dependency ratio usually expressed in percentages. That is what is a dependency ratio. What is the literacy rate? What do you mean by the literacy rate? We already had a word that the literacy rate could be adult literacy rate, where you see the number of people who can read and write. Yeah, read or write. Please note, it is the read and write. It is number of people who can read and write in any language. Age divided by age more than 15 years is what is adult literacy rate. And if we talk about the effective literacy rate is number of people who can read and write, age more than 7 years. All are multiplied by 100, both are multiplied by 100. So that is what is adult literacy rate or effective literacy rate in NFHS 5 data, the data that I showed you just now. The NFHS 5 data, the data which I showed you just now, that is, we are talking about the adult literacy rates. So you see over here is the adult literacy rate, age more than 15 years. Next in line is what we have as a 5-by-5 MCQ topic. What do you mean by the disability indicators? Disability beta can be of two types. We can have a person type disability or event type. Person type, like a person is there and he is disabled. Disabled to do what? Either he is disabled for mobility or disabled for activity. Next is event type disability. So now event type disability, we can talk in terms of that this person was there. We don't talk in terms of that he's not able to move or there was limitation of the activity. We talk that he was not in good mood to work. So number of days of restricted activity. It may talk to you about the mental disabilities or depression or stress or things like these. Then there is bed disability rates, that the patient was on the bed. Of course, this corresponds to the limitation of the mobility. Then is work loss dates, again that same funda of depression. So either we can have event type disabilities or we can have person type disability. That is your question number 1. You should know the basic understanding. Very frequently they'll ask you which of the following is event type disability, which of the following is a person type disability. That's the only question. Next in line, to understand more a little bit more about disability, you need to understand what actually is a disability. How is it different from impairment, disability and handicap? See, impairment. What do you mean by impairment? Impairment means something which is wrong. Hai na? Your machine is impaired. Your something is, your device is impaired. We don't say my device is disabled. So impairment is anatomical loss or loss of physiological function. Any loss of anatomical organ loss, or loss of physiological function, that is impairment. What is disability? See, if a person loses the fingers of the leg or the fingers of the hand, if a person loses finger of the hand, that is what impairment, disability or handicap, that is impairment. So if a person loses the finger, the person will not be able to write. It will be difficult to write, right? You all can write. So you are able to write. That person was disabled to write. We don't say impaired to write. He has an impairment of losing fingers, and which caused a disability to write. So disability is loss of activity. Try understanding, it is a loss of activity or loss of action or loss of some activity, verb that you are writing, running, jogging, seeing. So all these are disabilities. What do you mean by handicap? Handicap is because he was disabled to write, you are able to write, you might be the best doctors in the country, that poor fellow could not even become a doctor. So now he wanted to be a doctor, but he is not able to become doctor, not because he doesn't want to be, it is because he's got an impairment and a and a disability. So if there is loss of social role, he wanted to become a pilot, he wanted to become a doctor, he wanted to become a military person, army man, or he wanted to become a policeman. So something like that he wanted to become, he's not able to provide his society the role he wanted. So loss of social role or loss of occupation or loss of job, yeah, loss of money in terms of the occupation loss or the job loss, that is all called as handicap. So if a person has some impairment, loss of fingers, that is impairment. Because of finger impaired, he could not write, disability. Because of disability, he could not become a doctor, he could not join army, or he could not fly a plane, that is handicap. So you are doctors, you in clinics, what do you say? That you talk in terms of what? Impairment, disability, handicap. You always talk in terms of impairment. You never say that this fellow's kidney is disabled. We talk about kidney, renal impairment, hepatic impairment, pulmonary impairment. You don't say lungs are disabled or lungs are handicapped. We don't say that the liver handicap is there. So we talk in terms of impairment. Impairment is a clinical criteria. It is a clinical criteria. The people in politics, the people in government, the people who are in administration, they will always talk of handicap. In jobs also, we have a handicap quota. We don't have a disability quota, or we don't have a impairment quota. We have a handicap quota. Of course, the handicap quota is based on the Disability Act, but you actually have handicap quota. So handicap is kind of a more social phenomena. Social phenomena is what is handicap. So we in public health, we will talk about disability. Why? Because disability actually links the impairment with the handicap. So how to measure disability is what you are actually studying. Disabilities could be of two types, event indicators, or we can have person indicators. And next, you should also know there are some indicators which could be person type or the event type, or they could be both. So the indicators that you need to study for your exam is again a 5 by 5 star MCQ topic. This is what you need to know. What is a DALY? What is Hale? What is QALY? And what is Sullivan? So what do you mean by DALY? DALY stands for, I'm going to discuss each one of them now. DALY beta stands for Disability Adjusted Life Years. DALY, it stands for Disability Adjusted Life Years. What do you mean by DALY? Just look at this diagram. I have a beautiful diagram over here. If you look at this diagram, can you see that this child was there? Now a person who is born, and the person will go on his life, and in the end everybody has to, like, unfortunately die, right? That's how the life goes. So a person is born, and in the end they have to complete the life circle, and they are no more. That's how it is. Let us say that the person was supposed to die at 80 years of age or 70 years of age. Okay, just imagine. So that's what is the life expectancy we have. So due to certain disease or cancer or any problem, that person actually died at 60 years of age. Just imagine. I'm giving a hypothetical example. So how many years of life did the person lose? He was supposed to live till 70. The person actually lost 10 years. So what is this 10 years? We say that the number of years lost due to premature death, that is years lost to life. YLL. What do you mean by YLL? YLL stands for years lost to life. Okay. Now let us say because of the cancer, the person died at 60 years of age. For some years, he was on the bed. There could be some disability. He was not able to work, he was not able to go to the office, or he was not able to recreate or do whatever the life demands for. So that is what is the disability. So let us say for 5 years, poor fellow, he was on the bed. So for 5 years, he lost that life years. Why? Because not of premature death, but because of the disability. That is called as the YLD. What do you mean by YLD? Years lived with disability. YLD stands for years lived with disability. So now you have understood 2 points, that there could be YLD or YLL. Including both these things, the YLDs and the YLL, is what do you mean by DALI? What is DALI? Beta, DALI is a composite indicator. It includes both years lost to life and years lived with disability. Years lost to life and years lived with disability. So it takes into account what? It takes into account disabilities and premature deaths both. It takes into account both these things, the premature deaths and the disability. Please note, frequently asked MCQ, different faculties, different people, different books, different platforms may answer you differently, but that's how the government of India, that's how the UNDP, United Nations Development Program also works. That what do we use the DALI for? Please note that DALI is one of the best indicators for how much is the burden of a disease on a person. So the burden of disease, how severe the disease could be, is measured by what? It is measured by DALI. It tells you about the burden of disease or the severity grade of disease, that is what is DALI. So let us say a person gets disease A, and because of disease A, if the person says, because of the disease, the 5-year prognosis is very poor, the person is going to die maybe 20 years in advance. So of course the DALI has to be more for that particular disease. Are you getting it? Or let us say because of that disease, the person has to live for many years with disability. So DALI has to be more. So DALI actually tells you the problem, the severity problem, the public health problem coefficient of the disease. So it tells you about the public health problem. It tells you about the level of public health problem of a disease. Do you know that which disease has maximum DALI? Can you think of cancers, think of coronary artery disease, think of tuberculosis. I bet you would not have thought that DALI is, do you know, it is maximum for what? It is maximum for such a big disease and yet so common, that is depression. Depression has the highest amount of DALI because it causes more amount of YLDs, years lived with disability. Depression, anxiety, and some of the mental disorders, psychiatric disorders, they have the highest DALIs. So that's how you understand or interpret DALI. Please note that DALI, you don't say that it is not used these days. We use some better indicator. Nothing like this. Please note DALI is the best indicator for burden of a disease on a person. Next in line, how to understand what do you mean by the QALY. What is QALY? QALY stands for Quality Adjusted Life Years. QALY stands for Quality Adjusted Life Years. What do you mean by QALY? If you just look at this diagram. In this diagram, what you can see over here is, let me just simplify the diagram for you. Let us say a person was born at 0 years of age. And let us say that person was supposed to die by, let's not keep it as 100. Let us say, to be realistic, let us say the person was supposed to be dying at 80 years of age. Just imagine this. So a person was born at 0 years, of course, and the person was supposed to live till 80 years. Now, for some disease, I don't know how it happened, but let us say that person unfortunately got HIV at age of 30 years. Just example. So unfortunately, that person got HIV or cancer or any disease at 30 years of age. So now that person got cancer at 30 years of age. So obviously, he had to take some medications. He got some severe infection and the quality of life. Think on the word quality of life dropped. Because he has to go to hospital, he has to spend so much money. He could not afford a good car. He could not afford a bigger house. So the quality of life actually dropped for that person. And subsequently, he lingered on with that quality for next 20, 30 years. At the age of 60, unfortunately, we lost that patient. So now, what do you understand by QALY? QALY is Quality Adjusted Life Years. Now, let us say that you are the health minister. You say that people get HIV. No problem, we will start giving them ART. You give ART to everybody. So you start a treat all strategy. So whatever the CD4 count is, we are going to give ART. If you give ART, let us say that person who had got HIV at 30 years of age, now he starts taking your drugs. Now his quality of life will drop slightly, है ना? But it will not zoop very low. So the quality of life will drop and he lingers on with that quality, is little bit drop, and he goes on, and then he also goes on for extra, and he unfortunately dies at 75 years of age. Okay, so now there are two things. With your intervention, listen to the words, with your intervention, you are the big boss, you are the health minister. With your intervention, that person had an increase in the quality of life. There was an increase in the quality of life, and also there was increase in the quality of life years gained. Two different things. It increases the life years and it increases the quality. So if you match both these things, that is the how much quality life years are gained. And did you understand these words? Number of quality life years gained because of an intervention. Because of an intervention. By whom? By the government of India. By us, if we do an intervention, how many quality of life years will be gained by the general population? That is the indicator of QALY. So what do you mean by QALY? Please write it down, QALY. So let's just write down what do we mean by QALY. QALY for your exam, please note QALY stands for quality adjusted life years. So if you talk about QALY, what are the MCQs which can be expected? It tells you about the effectiveness. Mark the words. It tells you about the effectiveness of an intervention. It tells you about the effectiveness of an intervention in terms of money or the finances which are spent and gained. So it tells you that in terms of the finances, how much money you spend in an intervention. You can have different interventions. Can you see this? If I just clear the lines over here, I just make it a little bit more easy for us to do work. Let us say I could have intervention 1, which you see in this blue shaded area. Let us say there is another intervention which increases the lifespan more, but the quality of life could be less. Are you getting it? Or there could be intervention which increases the quality, but the life is same. So different interventions we can have. So which intervention to be actually put forth in the community will be dependent on the level of the QALY. So it tells you about the number of quality life years gained due to an intervention. So number of quality life years gained due to an intervention is QALY. It measures the effectiveness of the intervention. It talks to you in terms of the money spent, money gained. That is what the MCQ was. What do you mean by QALY? QALY will talk in terms of the money spent, money gained. DALY does not talk in terms of the money spent, money gained. It tells you about the burden of disease on the population. That is what is a DALY. Next is, what is this HALE? HALE stands for beta health adjusted life expectancy. HALE. So just try to understand what is HALE. HALE is telling you the number of years spent in good health. That is given by a HALE. Let us say that we live in a country A. Let's not talk about India. Let's say we live in any country A. In that country, I lived there for 5 years. Just imagine I'm decreasing the time and I'm changing the country. I lived there for 5 years. In that 5-year period, that country had a lot of infections and malnutrition, very poor. So let us say that in 5 years, I got diarrhea 3 times. Every time with diarrhea, I had to take a bed rest for 2 weeks. So for how much time? Like you got it for 3 times. So you got 6 weeks. So 1.5 month out of total 5 years I spent with treating myself with diarrhea. Then I got malaria also 2 times. So because of malaria, each time 1 month I was sick in the bed. So for 2 months I was with malaria. Then I also got a lot of dermatitis and itching. Lot of infections were there. So I spent maybe 5 months in dermatitis also. So total you can see that total I spent 5 plus 2, 7 and 1, 8. 8.5 months I spent in poor health. So how many years did I spend in good health? That is what is a marker of HALE. So just try to understand that it is different from DALY. Different people, different platforms, different books will say that HALE is a better indicator, DALY is not a better. Please note, I am saying it again. DALY is one of the most important. It is one of the best indicator for burden of disease. It is the best indicator for burden of a disease. But now the problem comes that what is HAIL? HAIL is a positive indicator. It is a positive because it talks about good health. Number of years you spend in good health. It is a positive indicator. It is calculated by the life expectancy in a country. Mark the word country. It is usually HAIL. We don't say for one person or one disease. We calculate HAIL for a country level. So life expectancy minus the DALYs of all the diseases, different diseases. DALY of diseases. So burden of diseases that you subtract from the life expectancy, that will tell you that at the country level, how healthy the population, number of years which are lived in good health by a population in a country is what is HAIL. HAIL is one of the best indicator about what? It is the best indicator about the health status. Health status of a country. HAIL is a good indicator about the health status in a country. It is also a very good indicator. HAIL is also a very good indicator about the efficiency of the public health system we have in the country. So it tells you that how effective your government health system, because health is a state subject. Health is done at individual level, community level, at the government level also. So it tells you about the efficiency and effectivity of a health system of a country. So HAIL will tell you about the efficiency, effectivity of a healthcare system, how robust the health system is there in the country. That is what is given by HAIL. HAIL will also tell you about the health status of the country, which is of course dependent on how much the government is spending. So HAIL is very important indicator. It tells you about the health status of the population. DALY on the other hand is a burden of disease. Okay. Next is, what is the Sullivan index? Please note that Sullivan is an index. It is not an indicator. It is a composite indicator. So it is usually dependent on something. It is dependent on the age of a person. It is dependent on the prognosis of disease. It is dependent on the type of disease, upon the grade of disease. That is all dependent. It is for individual person. So how do we calculate the Sullivan index? It is simple. It is the life expectancy in that area minus the DALY of a disease, minus the number of years that person is going to live with disabilities at that particular age. So if a person gets a cancer at 20 years of age, probably the Sullivan index will be different. If a person gets cancer at 80 years of age, the Sullivan index will be different, because it is the life expectancy, what is number of years which are remaining of that person. It is actually equal to the HAIL, but HAIL is at a country level, so Sullivan is at individual level. So number of years that person is going to spend in good health. Number of years a person will spend in good health, free from disability or premature death, that is the Sullivan index. It will be dependent on what type of disease, what grade of disease, at what age that person will get. So Sullivan, just remember that Sullivan is only an individual. It is a person type indicator. It is a person type indicator. We don't use it at the country level. At the country level, we talk about the DALYs, the QALYs, and the HAIL, which are more important. So with that, you have finished all the indicators which can be asked to you, all the health status indicators which can be asked to you from MCQ perspective. Next in line, we are going to talk is about the international classification of disease. Beta, the international classification of disease can be of various types. The WHO have formulated different types of classification system. We can have international classification of disease. We can also have international classification of health interventions, international classification of functioning, disabilities and health, and some other indicators in classifications like the oncology classifications, primary care classification, and nursing practices. We as doctors, we are important for us from MCQ point of view. The question can be asked about the ICD classification. The latest ICD that we are using, International Classification of Disease, is the version 11. It was launched in year 1st of January in year 2022. So it's just a very recently included ICD 11 classification. So let us have a few questions on the ICD 11 classification for your MCQ exams. It is kind of little bit different from the ICD 10 classification. In ICD 11 classification, we now have total 27 chapters. In reality, these are like 26 chapters only, which are the disease chapters, plus you have one extra chapter. That extra chapter is called as a chapter X. Chapter X. So this chapter X, it in reality, chapter X, you can see over here, chapter X, it defines the extension code. In the 26 chapters that we just now talked, in these 26 chapters, there are some new chapters. The new chapters has been for disorders of the immune system. The new chapters has also been for disorders of the blood and the blood forming organs, diseases from the blood forming organs, conditions related to sexual health is a new chapter, sleep wake disorders is a new chapter, and traditional medicines is a new chapter. So these are some of the new chapters which have been included in the ICD-11 classification compared to the ICD-10. In ICD-11, you can remember that there are 26 plus 1 new chapter, total 27 chapters. Apart from this, there is another point for you to remember is that in the ICD-11 classification, now there are 4 codes, 4 character code. It is a 4 character code and each character will have a 2 subcategory code. What do I mean by this? Can you see over here that if we talk about the COVID-19, how is it classified? For COVID-19, if the virus is identified, the classification code is RA01. So now you have a 2 alphabets and then you have a 01 and followed by that there is 10. So this 2 subcategory code, this is actually optional. It is optional. So now you have basically every disease is like a 4 character code. So just remember, like, it's very easy to memorize, or in fact now the WHO, they have given us the better browser tools also. So it has become actually easy for us, because in ICD-10 classification, do you know that was a 2 character code for which was again subclassified into 10 points. So 10 numbers you had to see. So now it is very easy. You just see the 4 character code. So that is what is a 4 character code. You can see over here that the post-COVID condition, the character code is RA02. That's it. So RA02 will have 2 other sub options like post-COVID condition, which was unidentified COVID or identified COVID, and different subcategories can be identified. Next is the second point was the 4 character code. Third point that you need to memorize is that the chapter numbers are now not Romans. In ICD-10, it was the Roman numericals. Now they use the Arabic numericals. Arabic numericals means 1, 2, and 3, the normal English type numerical that we use. So there is a better browser application, mobile application based tools is there, and there is a complete chapter description. It is kind of more improvised, more IT technologies being used in ICD-11 classification. So these were some of the MCQs which you can get about the new ICD-11 classification launched in year 2022 in January 2022. So with that, thank you so much for watching this whole module about the health status indicators and ICD-11 classification.